Ebony, this is Jared, and we're going to talk to you about
Spondylolisthesis. Say that 5 times fast. For our objectives is just to learn distinguishing factors about spondylolisthesis, identify potential causes, signs, and symptoms, determine appropriate tests and measures for examination, and to discuss plan of care interventions and outcomes. So what is spondylolisthesis? It's described as an anterior slippage of vertebral body. It's an inability to resist forces in relation to the inferior segments. Mostly occurs between L5 to S1, and most often leads to lumbar joint instability. And it's graded on severity on a scale of 1 to 5. So here we have a picture just kind of depicting this right here, that forward slippage. And then the next slide, we have the actual x-ray of a patient that has this right here.
Alright, so the causes for this condition are basically surrounding effects of it. So it's aging, syndesmosis, loosening during the flexion of the sagittal plane, repetitive motions leading to the stretch fracture. It has no real cause, but it's traumatic incidents, so like people falling. It's very common in strokes and sports injuries. So the clinical manifestations is the radicular pain, loss of active range of motion and passive range of motion, increased lumbar muscle tone, increased hamstring muscle tones, low back pain, sciatica, muscle stiffness, and that's tightness, glute pain, and stiffness. And as we all know, the 9 times out of 10, when you have lower back pain or any kind of back pain, that means tight hips. So that's why a lot of the stuff are coming from the hips and the glute area.
So for some functional limitations, we have just inability or difficulty ambulating or mobilating. We also have inability to stand for prolonged periods, and also inability to sit for prolonged periods. Also, incontinence is also a functional limitation. Inability to garden, get out and do stuff. Patients are unable to, chase grandkids, work out, lift weights, cardio, all that stuff. So whenever I was in clinic this past summer, we had a patient that had this condition, and she's unable to stand at church for a long period of time. And then she sat down, and that was uncomfortable too. She couldn't sit. It's just no matter what she did, she's uncomfortable, in pain, hurting. So there's just an example of that. So tests and measures, you got your manual muscle testing, MSTT, active passive range, but it's mostly X-ray, MRI, and CT scan to determine if the patient has this condition.
All right, so for differential diagnosis, we have the different pathologies. So spondylitis. So spondylitis is really just a general term for inflammation around the vertebrae in the areas of that inflammation that cause the functional limitation. While the one we're talking about today is when it gets so inflamed to the point it pushes forward the vertebrae. So that's how you can tell the difference of that. You have vascular dysfunction, PVD, osteoarthritis of the hip, myopathy, spinal tumors, and infection. And the way we can figure out, differentiate these two is utilizing, looking at the symptoms. Imaging will be helpful. Mechanisms of cause, reproduction of symptoms, as Dr. Carter was saying last week, I think, that a lot of these back conditions, they are in the same area, same region, so they easily can be interpreted as something else. But the different tests we can do to reproduce symptoms will tell you the exact causes. I think that was mostly the hallmark for how to figure out each one. But imaging will help as well. So MRI and CT scans too. So the interventions we can do is emphasis on posture. Posture is very important for these conditions because people don't realize the way we stand and hover, lean forward, like kyphosis, lordosis, and all that stuff, that can cause a lot of back trauma, back pain. So we need to tell people to focus on posture. Education on posterior pelvic tilt, that's important. Physical therapy, therapeutic exercise and stabilization of the core. Antalgic and anti-inflammatory conditions, modalities for pain modulation, and sometimes surgery is indicated, usually for spinal fusion. And that's exactly kind of what my dad had too, for the lumbar area. So for the different stages of this condition, we have the max, moderate, and min protection. So basically in the max protection, we want to take it kind of easy. We're going to use some isometric conditions, contraction of the fundi of the abs and flexion, isolation ab exercises in the hook line air position, contraction of the multifidus and flex position, contraction of the spine during ADLs, resisted cane, isometric supine. In the moderate, we're gonna continue to progress. We're gonna do some arm and leg raises on the contralateral side, prone trunk lifts on the exercise ball, abs and crunches exercise to build up the core. And then for the men protection, that's when our patients probably get to that area where they can do a lot more than what they're doing in the max and moderate. So we're gonna continue to exercise, but kind of progress it a little bit more by making it harder probably to do some restriction exercises. Increase distal extremity weightlifting and lever length resistance. Stand exercises without outside resistance and non-local muscle strengthening exercises.
And then here we just have like, a picture depicting some of these exercises that are kind of common for this condition. So you got your like gluteal stretch, pelvic tilt is a big one. Then just like a lot of ab exercises and stuff right there. All right, so outcomes is case specific for each individual. It's going to be different. Usually rest and non-surgical treatments, bring relief within several weeks. Patients will start seeing some relief. Spine flexion may be limited after surgery. There's usually a regression to prior symptoms possible, if it's a higher grade of this condition. And generally, people can return back to activity within a few months. And for overview, spondylolisthesis is an anterior slippage of a vertebral body. It can result from multiple different pathologies, and usually, it's difficult to rehab, but it may require surgery in some cases too. Resources right here.